So we've got three sort of major items today to get through. We're going to have a bit of a talk around sort of metrics, frailty, the concept of sort of population health management, and our colleagues from Next are going to talk us through that, and that will probably most of the actual agenda. We'll spend probably a good 55 minutes to an hour on that, guys. Does that sound about right?
Yeah, that's fine, Dan, thank you.
Okay, then we'll be having a little bit of chat around a project called Rita, which is sort of work that looks at sort of dementia in care homes, and we'll probably spend about 20 minutes on that. And then for the last half hour, we'll probably try and have a little catch up about what's been happening in the world of frailty and have a little conversation between ourselves about what's been going on in everyone's lives around, working lives around frailty. So before I start, am I forgetting anything else, Anne?
No, you've covered everything there, Dan.
Perfect.
Yeah.
Well, what I'm going to do is stop sharing my screen and hand over to, is Bob and Alice first?
Yeah, I believe so, yeah.
Yeah.
It is, Dan. Just a quick introduction from me to what we're going to be doing. I think many of you, if not all of you, will know the old quarterly metric report. I think it's probably fair to say that the format of that report has stayed, and so we wanted to really look at the report again, revamp the report again, and give you a view of the report that didn't just give you the current snapshot, which is what the old report did, but also allowed you to look at some of the new commissioning geographies, primary care networks, ICPs and stuff, as well as your usual locality view. So Alice, who's one of the brilliant analysts in my team, has been looking at that report. So I was just going to talk you through that. We've only got 10 minutes for this session, so it's going to be a real rattle through with a bit of speed. But we'll be sending out the report after the meeting, so you can have a look and give us your feedback. So I'll pop back after Alice has talked you through the report and give you a few examples of what it looks like, to tell you what the next steps will be. So, Alice, if that's okay?
Yeah. Am I okay just to share my screen? Am I right to steal it off you? Can everyone see that Excel file?
Yeah.
Okay, so I've basically used the existing metrics that we had before on the PowerPoint iCare document, but I've added a little bit more to it. So we've got the PM breakdown that Bob mentioned, and also some historic data in there now. To do that, I've had to put it onto Excel, so it's a little bit more robust and you can sort of use the filters. So I'll jump into a few of these. I don't think I'll have time to go through every single metric, but this will be sent out at the end, so welcome any comments on any of the ones I've not been through. So just as an example, if you just click these headings, it takes you to the metric that you want. And then clicking this next sort of top corner will just take you back to there, just to make it a little bit more simple. So one of the first metrics I'll just use as an example, the proportion of patients aged 65 plus. So this is just one of the standard demographic measures that we've had before. But what's changed has, we used to just have a CCG level. We've now got scaled up to ICP and also a PCN breakdown. So for example, if you look at Newcastle with quite a low proportion of patients aged 65 plus, you can click Newcastle here, have a look at the actual PCN breakdown of that. So you can see that Jesmond's got a higher proportion of aged 65 plus, and Newcastle Central has a lower proportion. Now that might be because of students, etc., but it could be anything. So you can just click through these and have a look at further breakdowns into that area. And the orange line here is the CCG proportion, so that's just reflecting back to this, so you can see which of the PCNs are bringing that down or bringing that up, for example. And then we've also got historic data, so you can sort of click through to the previous quarters and see if this has changed. I think with this metric it won't change that much, but some of the other ones I'll show you might have a little bit more variation. So another one that might be worth showing is just go back into here again. Proportion of patients who live in a nursing home. So again, you can see the variation through PCs. I've clicked this onto Gate just to show you there that there is quite a lot of variation we might not have seen before. So there's a high proportion of those who are in nursing homes here than there are here. So that sort of can skew the average when you're looking at a CCG level. I'll just click through a few other examples. I've sort of tried to see where there's some good examples to show you. So the flu vaccine. So this is the uptake of the flu vaccine, and this is the latest data. So this is October 2020. Again, you can sort of see, for example, if you look at HRW, you can sort of see which PCNs are underperforming or overperforming, or Tees Valley. You can sort of see that they have quite a low uptake, but within the region, there are actually some PCNs that are performing quite well.
Alice, can I ask a question? Sorry, it's Kim. Is there any reason for the flu why we don't get that system level view, sort of because the demographics were split into the ICPs? So you go one level up almost, don't you, and then down to the PCNs?
Yeah, I'm not sure one. I think the ICP level wasn't inbuilt into that, but if that's just a case of combining the CCG to make that up, then that can be added quite easily.
Okay, brilliant.
And then also frailty assessments. So proportion of patients aged 65 plus who've had a frailty assessment. So I'll just have a quick look. So the DDES is coming out quite low here, but for the PCN level, we've got some that are performing quite well, and again, some that aren't. That's just another example there of the variation between PCNs. And then you can also flick back between the quarters. And then also, there was one that stood out. I just wanted to show. It looks like a little bit of an anomaly. I can't say the word, anomaly. So for North Cumbria, they have quite a high portion of assessments being carried out, but for these particular two CNs, it seems to be abnormally high. So when we have a look at North Cumbria here, we can see that it's these two particular PCNs, and it looks like the blanket just said that that have had an assessment fall under non-mild for the frailty status. So that could be wrong or right, but it's something that does stand out and might be sort of something to flag. And then also, I've added this little bit in for additional frailty assessments completed. Now we've got a little bit of historic data. You can see just by CCG numerically how many more have been performed. And this should just to say how many have been performed since between April 2019 and March 2020, and just a cumulative chart just to see where we're actually at the moment compared to where we started. So that's the assessments. One more example I'll just quickly give you is we've got a mutation metric. So the ones that have had who've got severe frailty and have received an annual medical review. So again, we've got the different levels for this. And we've also got the polypharmacy data. You can see how many have been prescribed 10 or more unique medicines within this. This is quite a good one to look at for the time series, because from Q1 to Q4, there's a massive jump up in all of those areas. And then you can also see that at PCN level as well. So that's a quick rush overview. We've also, just to point out, I've kept Gateshead and Newcastle separate. I've been told they've merged, but it's still quite useful to see that separated. So I've tried to keep that as separate measures so you can see that as a breakdown. But yeah, that's pretty much a quick overview. So I'll open up for feedback questions, but I will be sending this out, so don't feel free to have a proper look at some point.
So I see Jenny's probably got a hand up.
Yeah, so hi Alice, lovely to meet you.
Hi, you too.
I think this looks fab. I think as a starter for 10 from where, you know, what we asked you to do and work on, I think it's fantastic. I think what we need to do now is to work with colleagues on this call, our ICP leads in the 4 areas, and ask them to go back and talk to their teams about this within the PCNs, and feedback. You know, what works, what doesn't work, how useful is it, what is it telling us, and how can it help us make better decisions moving forward. So my suggestion as an action from this would be to ask that this is disseminated through the coppers here today and the ICP leads, and almost put a bit of a time frame on expectations of feedback, assuming that no feedback is good feedback, but also then asking, so how are people going to use this, so that we've got some assurance that it's of use, because there's no point doing anything if it's not going to be used and useful. But a massive thank you, because I think it's a cracking bit of work.
Oh, thank you. Yeah, I would agree with that. I think it'd be good to get the feedback on it, because obviously they're the ones who are going to be using the data. I've just done it from my point of view. So yeah, I agree on that one. Thanks for your feedback.
Absolutely, it is really, it's moved on massively. Thanks, Alice. And Leslie Young Murphy's got a hand up as well.
Oh, yeah, thanks. And thanks very much, Alice. It's been a long time since I saw the data set. And we do take it to our transformation board, so that's how we use it. But it looks great. The one thing a query, maybe suggestion, I don't know if it's possible, but in terms of the frailty assessments, because obviously it's helpful to see the numbers going up, but I wondered in terms of if we could overlay the anticipated number of frailty assessments based on demographics, and then what the regional and what the national comparators are, because I think sometimes people seek solace in terms of seeing things going up, but they could still be way off the mark in terms of what we would expect to see in terms of our population. So I know we would find that very helpful.
Yes, I think any data where we've sort of got an expectation level, that's something that I'd add into anything. So yeah,
great,
thank you. Take that on board. Thank you.
I think that'd be really useful. We could probably spend all afternoon talking about frailty assessments and codification of them and things. Can I just clarify the actual assessments, because them 2 anomalies, is this the EFI code or is this the CFS code? Because obviously one's the clinical confirmation and one is just the electronic alert sort of thing. So I was just wondering if we could clarify for the group.
It's I'll answer that one, Dan. It's the people who've been coded as having an assessment, so it's not AFI, so it's the validated assessment. So it looks like batch tracing, batch coding, to be honest, in Cumbria.
Unless they've done an awful lot of work, but yeah, sorry, Kim's jumping to their defence, but it depends. Yeah, that would be an awful lot of frailty reviews to do. I do understand that.
Yeah. I do really like Leslie's idea of predicted sort of numbers still left to do, because as you can imagine, all the stuff with the DES coming through and the PCN stuff and the medicine reviews and everything like that will be useful for PCN starting to see the numbers.
Yeah, definitely. Yeah, we can add that in wherever those numbers, definitely.
And I think Andrea Brown's got a hand up.
Hi, Dan. Naturally, I have my hand up for this sort of, Bob will be pleased to know. It was just say, hi, Alice, and just to say, I'm not sure if you've seen, but the original version of this metrics report was produced back in 2018, probably before you were in post. I don't know if you've seen the original document or not, or whether you've just been working on the version that Next picked up. But there were 23 metrics in the original version, and I'm not sure where some of them have gone, but they may have gone for good reason. It was really just to say, yes, it does look like a really good functional piece of work. I will comment offline to both you and Bob separately. It was really just to say that it's useful to see all of this variation at ICP and CCG and PCN level. What may be missing, and it may be because I can't see it on the screen, is how we compare against England. So we might look really good regionally, but we haven't got a national benchmark to bring us down to earth where we need it. And that might be the case in some places rather than others. But other than that, I'm happy to comment offline once I've seen it properly, as you would expect, and I'll speak to you later about it. No worries. But it looks great. It looks really good. I like the buttons.
Great.
Thank you. I think there's a couple of mixes that have got the England baseline in, but you can definitely have a look round to add those into some of the others. But yeah, thank you for that. That's great. And could we pick up Andrew as well, just regarding the metrics per se, because I think we've obviously been looking at some of the metrics to try and get some new data information from different areas, because we always lack a little bit around sort of the wider determinant stuff. So if we could pick up that conversation just as these evolve over time would be really useful as well. Yep. We are data hats on. Right, I can't see any more hands up there, but do keep me right if anyone has got the hand up.
Can I ask one quick question, Dan, before you move on? Is it, in terms of dissemination, do you want us just to email out the file to everybody, or do you want it go onto the website?
I wonder if I could pass it to Anne Richardson, and Anne could then sort things out from there. Does that sound okay, Anne?
Sorry, Dan, I keep putting myself on mute. Yes, of course. Yes.
Yeah, it'd be simpler for everyone else if we just give it to Anne, and Anne can then sort the complexity out of sharing it.
Thank you.
Great. Well, thanks for that, Alice. That's really useful to see, and it's moved on loads. So should we move on to the next section? And I think this is more of a two-way conversation piece of work, and we've probably got about a good 40 minutes or so to kick this off. So who should I hand over to? Is it Ian or Kim?
I'll pick it up, Dan, if you want, because I've got a couple of slides to show. So hello, everyone. I'm Ian Nicholson. I'm Head of Clinical Commission Intelligence at NEX, and I may be supported by Kim Teasdale, who will introduce herself in a moment. And what we want to do really is it's great that we've seen kind of metrics on the state of play, if you like, around frailty in all those different areas that Alice has whizzed through there. But what we want to bring in today is kind of to actually use your experience and knowledge of work in this field to look at how we might improve how we spot people on the frailty pathway, how we spot people who may be deteriorating from the data sets that we don't routinely crunch and present like Alison has done there. So I've got just a very short presentation, and then we'll just kind of open up for a broader discussion, just so we can get some more insight from yourselves and how we might kind of improve this approach. So I'll share my screen. You should have just a bright blue screen on there now about aging well through a population health management lens. And apologies, I've missed Alice off the bottom of there, putting it onto the front page. But basically, just a couple of things really. First, in terms of population health management, a lot of you have probably heard that this phrase been used, almost a buzz phrase that's been around for a year or two now in NHS England. But I've just put the definition on the screen. Again, these slides will come around. But you know, a population health approach is aimed at improving the health of the whole population. It's physical and mental health outcomes, it's reducing health inequalities, and looking to address a wider determinants of ill health. So, you know, quite a tall order there. The population health management approach is about using data to underpin the evidence to drive the change really, and have the maximum impact on people. And there's a lot of different ways that we cut and slice and dice data, which I won't go into in that dark blue box there. But basically, what we're looking for is where cohorts of individuals are in need of the same treatments or have the same conditions, and where there are differences, be it between cohorts, across a geography, across a system wide, even just think about some of the stuff that Alice has shown you there. And the idea, kind of a very simple idea behind population health management, is if you look at the triangle here, so as you look through the different coloured bands there, we've got different segments of the population there. So at the bottom, most of our population tend to be healthy and resilient. And as you move up that up that triangle, people start to develop risks. They have low complexity needs. They develop diseases and have ongoing care needs. And at the top of that triangle there, we've got people with complex needs and basically people who have been case managed. And that's a view across the whole population. We could actually use that similar view across the kind of the five phased areas from the frailty. And the idea between a population health management approach really is to prevent people deteriorating and moving up the triangle, and where possible, in some cases, is to bring people back down that triangle. But understanding the kind of the characteristics and the makeup of those populations is one thing, and that's what we're going to try and tease out today in terms of some other things we might look at. But actually, what's the most important part is actually then delivering and design interventions which can be clinical and non-clinical to actually meet the needs of that population. And I think when we were discussing this with Dan and with Jenny a month or so ago, we felt that in terms of the intervention space, if you like, we know a lot about the things that we should be doing. And where we wanted to just lead the conversation today was about identifying, through a life course, and again, that's another much used phrase, but how we might collect data, identify individuals, what data should we look at in order to support people on that journey through deteriorating frailty, really, so that we could intervene earlier and actually prevent people from moving into the next stage and moving up the triangle. So I've stolen your Jackie persona, which I thought was great, and I probably haven't done it justice on this slide here. But we're going to try and identify what are the risk factors and what we should be looking out for. So as people move, I mentioned before, from fit to pre-frail, the mild, moderate, and severe frailty, and some of the evidence that was on the iCare website that Dan kind of gave me a link to, there's some great stuff on there. I've just taken a couple of them off there. So as you go from the fit to the pre-frail area, we see that evidence of slowing down, to coin that phrase. And then as we're moving through from perhaps pre-frail into mild frailty, we see individuals developing illnesses and kind of comorbidities coming in. And then again, as we move along from left to right, some activities and for individuals become more problematic, to the point where we get kind of from the moderate to the severe, where there's of care. So that was just kind of just to set the thing. So we're trying to build it around the Jackie persona, because understand that the group, this community of practice, are familiar and actually were instrumental in developing that. So I think with the agenda, we came out just what we want to do today. There's a few prompts, and hopefully people have had time to give this some thought, but I'm sure in the next kind of 30-35 minutes, the ideas will spark off one another. But the four areas we're really thinking about was, I'll just go there. So thinking about Jackie or that persona. So from your service perspective and where you sit within the kind of the frailty delivery and care model, when would you have contact with the likes of Jackie? Which part of that frailty pathway, and also very importantly for us to do the kind of the data and analytics part of it. How do you currently identify people who need to access your service? So we're big on data, on health data. We can look at disease trends and things within people's health records. But what we don't know are when people just kind of start reaching out for help from a lot of the kind of the broader services, rather than purely things like primary care and secondary care. And we just want to just understand really, what information do you have about these individuals, and just how do you use that information? Because we're looking for ideas on how we can just get a kind of a broader pitch on what's going on in individuals and cohorts in order to spot these kind of these steps between frailty. I'd also just like to tease out again the people that use your service. What are their main characteristics? We're not experts in the frailty field at all, myself and Kim. You are, so we just want to kind of pick your brains around there. And then I suppose the final point, which is probably where we'll turn it round after the meeting, when we've had a chance to consolidate the discussion, is what would then you find benefit within your service, so that you could identify citizens sooner, or more accurately, so we can get that almost that preemptive strike in to stop people moving along the frailty pathway. So what we intend doing is, I'll just leave that slide up. I'm going to take it off because I don't think it'll work trying to capture things live. So we're looking at, what things might you spot from people moving from that fit down to that severe frailty area, and where do you draw your intelligence, your data, your information from, and how do you do it, so that we can think about other things that maybe we should be capturing, so we can get a much rounder picture of people on the frailty pathway. So I'll stop there and we'll get into some discussion. If you wouldn't mind, if we'll start a discussion and see how it flows, but if you could just introduce yourself, but actually tell us which service you're from, that would be helpful for me and Kim in particular. I'm sure you all know each other better than we do. So we just open up to the floor, please. That's okay. I should have stopped sharing my screen. I don't know if I have.
Is it worth putting the slide back up with the questions on it, Ian?
Yeah, okay, I'll just go back to that one, Kim. Sorry, yes,
Sorry.
good idea.
Just keep me right with hands up. I think I've got Andrea's hand up. I'm not sure if that's a historic hand or a new hand. Oh, that's came down to historic. So it's a bit of a complicated sort of conversation to get in. Ultimately, in my head, as Ian was talking there, just putting my GP hat on, what I probably am thinking about is, how do I get to see Jackie at different stages in his life, and how could I get to see Jackie earlier so I could do something to probably help Jackie, his family and carers, to make sure he doesn't slowly progress without actually having any sort of access to things that could prevent frailty or support him at times of crisis. And we just want to see how people meet Jackie in their professional life, really, and what sort of information do you keep about the types of Jackies in your organisations. So I've got Karen, I've got David and Karen. I'm not sure who was first, but do you want to go first, Karen?
If I can unmute myself. Yeah, I'm Karen Franks. I'm an old age psychiatrist in Gateshead. Hello. I suppose just looking on the slide and thinking about Jackie in terms of, well, obviously there's different parts of our services, but in terms of memory and dementia services, we would probably be likely to meet Jackie at the developing illnesses point, because at the point of developing a dementia. And I think you've heard me on about this, but I think we're bad at capturing the fact that realistically everybody with a diagnosis of dementia is on a frailty trajectory of some speed or another, and I think sometimes we're at risk of losing that because, for example, the EFI, if people don't have a number of comorbidities, the EFI might not pick them up because of the dementia, because we're not sort of coding maybe some of their functional disabilities as they go on. And also it's a factor of the fact that in the current health system, we are not good as a system of following people with dementia all the way through their dementia journey. And, you know, that's not a criticism of anybody. That's the way things are at the moment, and something we all know that we'd like to do better.
And just out of interest, Karen, like, how do you currently, like, where do your patients come from? Is it an active referral from another healthcare consultant, or
yeah,
know, like, how
from
does it...
general practice? Usually active referrals from primary care. Some come from other other healthcare professionals, or from hospital, or some bits of service have self-referral options, but the vast majority from primary care.
And how do you find the information you get about the patient? As in, do you have to supplement that quite a bit with when they come to your service, you do your own assessment, obviously,
yes,
to deliver that? Yeah.
They
come with some information, so you're informed
yes.
a bit about
them
as a patient?
Some information, we add to it. We're fortunate in Gateshead that we're on the same information system as the GPs, so we've got access to a lot better level of information than most people do. People come into mental health services.
Mm-hmm.
Can I put you on the spot, Karen? If we're thinking about the whole prevention agenda here, and obviously, because when I refer to you, I'm worried about memory at that point. Is there anything from your sort of knowledge, risk factor perspective, flag of frailty, mild, pre-frail, that sort of stuff that you think, oh, I wish I could have gotten in just a little bit earlier because that would have made a difference? Or do you think where things stand, you probably are seeing these people at the right point in time?
I think for dementia, as awareness has changed and as attitudes have changed, we're getting in earlier and earlier, and we're probably doing reasonably well for that. Not in every case, but I think we're probably getting in at about the right point. There is an argument that there's the sort of at-risk populations, and are we looking hard enough in our at-risk population? Cardiovascular disease and Parkinson's and things like that. On the flip side, I think the people with functional mental illnesses, so depression and psychosis and things, I think we probably aren't seeing early enough. And that's a whole combination of things in terms of accessibility, people feeling able to raise these things, and also, you know, service volume, because realistically, between primary care and ourselves and everyone else, there really isn't enough resource to support all the older people with mental health problems. So it's not a criticism of people not doing it, but I think if we're talking about improving population health, then being able to get involved earlier and more proactively in people's mental health conditions would make a big difference.
Absolutely, and it's probably trying to understand. I've been doing a bit of work looking at the bi-directional relationship with sort of mental health and dementia and frailty and chicken and egg and all that sort of conversation that's going on. So I see David's got his hand up, and then Lynn's got a hand up.
Hi, David Dawson. I'm the Falls and Frailty Matron for Northumbria. So just a bit of a secondary care perspective on this, I suppose. Thinking about where we'd come into contact with people, obviously we have Falls outpatient services, and we'd probably get people coming into Falls outpatients at various parts of that frailty journey. So that'd be one way of identifying it. We also see patients through an MDAC service, was a multidisciplinary assessment service, similar to sort of elderly assessment centres. So there's some outpatient clinics that we would probably pick that up at. More generally, we've got a frailty assessment service that work into ED, and when people are identified where frailty is actually the primary issue, they will pick that up and be involved in the management of that. So from that very discrete group of patients, we could pick it up there. More generally, we do a clinical frailty score on everybody who comes into hospital. We're still working on the accuracy of that. We're not 100% sure that we're doing the Rockwood score as accurately as we could, but that would be another way from a secondary care point of view of kind of picking up who's scoring where on that frailty scale as they come in. But it's how you feed all of that back and link it in with GPs and things that is the issue, I guess.
And just on that then, Debbie, so are the referrals into the services similar to what described by Karen? They tend to come from primary care, do they, into the Falls service and the MDAC, was it you said?
Yeah, so predominantly they're GP referrals in, although we do have a community Falls clinic run by the North Tyneside CCG, so we do get some referrals from them, but predominantly they're GP referrals. Okay, that come into the outpatient clinics.
Yeah.
And we did put on as part of the electronic discharge summary the ability to put the clinical frailty score on there when we do the EDS on discharge. But again, we've done a few audits, and we're not sure how accurate those CFS scores are being filled out by ED staff. Sure. It's an ongoing piece of work, that one.
Yeah, but I think it's important you try it and then see if it works, rather than say, well, they probably won't be very good, so we won't do it at all. If you're like, yeah. You know, that's been a bit flippant, but you know, it is about, and if it is great, well, what a great piece of intel flying around the system, yeah, that could maybe identify someone, and you know, so most patients.
Yep, yeah, there's pretty good compliance with it. Most patients who come in through ED have got a clinical frailty score done. The next part of that journey for us is, okay, how accurate is that? we're not. How reassured are we that everybody isn't kind of looking at the board and going 5?
5, yeah, it's somewhere in the middle, yeah.
But the next thing that we're going to try and do, for instance, is the CFS app, from the Acute Frailty Network. See if we can get people in AD to download that app onto their work mobile phone, for our nerve centre things. So there are things afoot. It's obviously quite a big topic.
David, can I ask a couple of quick things? So are all your people coming into your falls service getting a frailty assessment? Because I'm just thinking about primary care, and we obviously do the reverse. Any EFI, frailty, moderate, severe, we do a falls assessment. And also, have you heard of the new sort of, I was sharing with Bob earlier today, the new electronic frailty tool in secondary care linked with the HES data? Have you got that as part of your provider organisation?
Oh, so the second thing you said about the you said about the digital tool.
Sorry, Bob might know better, but there's a NHS Elect through the Acute Frailty Network, which a lot of our hospitals are part of, have developed an electronic tool using HES data to then code people's different level of frailty. It's on the NHS platform's website and on the AFF, the Acute Frailty Network website, but it is available for different areas to use, whether it's commissioning or provision. I just wonder if you've looked into that yet.
No, I haven't. If somebody could send me a link to it, I'll have a look in. I'll pass it on to Dr. Chaplin, who sort of leads, and Chris Moe, who lead those teams. And then in terms of your question about falls clinics, the answer is it depends. So the way we split the falls clinics at the minute is there's falls outpatient clinics, and then there's an MDAC clinic. The MDAC clinic's a multidisciplinary assessment clinic. So if you get people coming in with falls, that's kind of the primary reason they've been referred in. But it looks like they've got some other frailty things going in. Then they go into a multidisciplinary assessment, of which, and those people get a CGA. But then the people who, life's never quite this simple, is it? But then the people who look like they've got a discrete falls, usually syncope, for instance, they wouldn't necessarily get a CGA if they've come to us because of syncope. So we are in that stage of the where it depends. But certainly for the North Tyneside patients, the patients who go through the multidisciplinary assessment get a CGA, but it's a paper copy. And so that might obviously, in future, you would hope feed into some of the discussions that we're having slightly outside of this with the Health Call System 1 CGA platform that could get involved in that. But if somebody, I don't know if Anne maybe could send me a quick email with a link to the NHS Elect stuff, I'll have a look at it.
Right, Bob's got his hand up. I'm not sure if it's specifically about that, Bob. Did you want to jump in just before Lynn and Leslie? Or I think you're still on mute, sorry.
Sorry, talk to myself again there. Just on that, I have applied for access to that, but I haven't actually gone back in to look at it. So if you want to give me an action to kind of force me on, I'll do a bit of digging, look at that tool, and I can feedback next time if you like it. That might give you a steer, David, about whether it's worth running with it within the trust.
That would be great.
If I can jot that down, because that'll make certain I'll actually do it.
No problem. Now, I think Lynn was next on the list. Lynn Shaw. Hi, Lynn.
You're on mute, Lynn.
Oh, Lynn, you're on mute, sorry.
People wanted to mute me for years. Yeah, I'm nurse consultant for older people 2 days a week in Gateshead with community services, and 3 days a week I'm on secondment to the regional NCOP competency framework development as strategic workforce lead. So I've kind of got a couple of points, one from community services angle and some of the things we've been looking at in Gateshead. I think our opportunity to pick people up earlier is really often remembering, a bit like David was talking about, falls are one of the big frailty syndromes, but we have another 5 frailty syndromes. I think Karen was kind of, alluding a bit to impaired cognition. But those other kind of softer signs, like people who are accessing continence services or physiotherapy, or, you know, maybe not even at the fall stage, just the kind of unsteadiness, fear of falling. And I think that EFI, if it's all coded right, picks those things up, but because they hit all different parts of the system, you know, they might have been referred to a bowel and bladder nurse with kind of new or worsened incontinence, and that maybe isn't picked up, you know, proactively and triggering a kind of full frailty assessment or CGA. Over the last year, we've been kind of, the last year or two, developing within community services and Gateshead an interprofessional frailty training programme, which we're kind of, you know, we kind of offer that, and it's opening up across the trust now. But what we're just about to sign off is a frailty care standard for community services, which is kind of trying to get professionals working in those other, you know, we know that people get referred in for case management, you know, through the locality teams in Gateshead, manager, but really thinking about all those community services. So if somebody's hitting bowel and bladder and it's new incontinence, they should be thinking, is this, you know, the beginning of frailty or a frailty presentation, or if they're referred just for slowed walking to a physio. So, you know, kind of some of it learning and development, but actually kind of care standards and pathways and standard operating procedures and things that could divert people. And I think the other point there was really EFI is really good for proactive case find, but it's probably only as good as the stuff that's coded in there. So probably, yeah, maybe better at, you know, coding repeated admissions, multimorbidity, maybe not so good at the, you know, the other key frailty indicators like incontinence and things like that. So maybe if we were sharing that information better across the system, it would help the proactive identification, pick people up a bit sooner. Because I think I'm thinking about over the years, people who haven't got a long list of medical conditions and have never been to hospital, and all of a sudden you pick them up age 95 in a frailty crisis and think, where did that come from? But there might have been, you know, little touch points where they touched, you know, other services that could have been a bit of an indicator, raised the suspicion.
And that's really key then, that's it, you know, about, and, you know, we want to draw the technicalities of data, but the fact that they're in receipt of these different services must be getting recorded somewhere. What we're not very good at, and, you know, it's our hands up, is making sure we pull all that right intelligence from somewhere and then just put it through a very simple algorithm that says this individual has touched three services, you know, query of an investigation or, you know, an intervention, which might then draw a negative and say that's absolutely fine, they're waiting for this. But it is just spotting those clues, and, you know, they are clues, and it is a bit like, you know,
into some, as far as I believe it, the last time I looked at it, EFI is meant to do that, isn't it? But if people haven't got all the information, for instance, that someone's developed incontinence, one of the frailty syndromes, and it's not coded in primary care EMIS, then it won't contribute to the EFI algorithm kind of thing.
That's really useful. I mean, there's a lot of debate about EFI obviously going on, and I think I shared some work with Gareth Forbes, one of our colleagues down south, who's produced something that's been published around the identification of the frail elderly, and it's a bit more of a practical list as such around over 90s, care home, and that might be useful to share with the group. But that's been a published algorithm where he's identifying his group, and it's been through some national conversations as well. I'll just quickly jump to Leslie Young-Murphy, who's got a hand up, if that's all right, guys.
Thanks, Dan. Thanks, Lynn. I think you've picked up quite a few of the points I was going to raise. The in terms of the Community Falls service in North Tyneside, which is made up of a number of different partners, the Do Code for Frailty is part of that. I think one of the things that we did with our fire service, who are part of that, and obviously with COVID haven't been involved latterly, as part of their regular just well-being checks, was to look at the use of the time to get up and go test, because I think sometimes there is something different about the narratives you have with older people, but also not necessarily older people. I mean, if you think about the deconditioning that's gone on with COVID, you know, for a lot of people, in terms of which predisposes them to falls because of that deconditioning conditioning, but then also they're on that slippery slope if they don't do something about it. And as you know, Dan, we've done a lot of work, Steve Parry's led that, in terms of how fit and using self-efficacy scores, in terms of identifying those people who really could need to be seeing a full service. So I suppose that's also that early identification and intervention, prevention along that scale. And I think sometimes it's just trying to think about how can we do it as easy as possible, but how can we also make sure that we do some work with the public, with certain cohorts of people, to get them a bit more aware. You know, we've done a bit of work with carers, etc., around that.
Absolutely. That, I mean, the thing is throwing the net wide, isn't it, and trying to think about the reality of what risk factors really mean for, as you put everything together, really, because it is obviously bi-directional, a two-way type thing with frailty and risk factors. I know Leslie Bainbridge just popped her hand up there.
Yeah, I have. Thanks, Dan. I was just going to remind everybody that, you know, Jackie is a real man, and we do know a lot about his life that we're not talking about at this moment in time. But to answer your questions, Dan and Ian, about how we might stop frailty progressing and how we might optimise health and well-being and so on at whatever stage an individual is at, it's worth remembering this, that one of the things we absolutely know about Jackie is that he had 20-odd years of very good long-term condition management by his primary care team, where he was there at least 6 monthly for his long-term conditions. And if we were to go back and look at his primary care record, we would see that the things that we measured, the bloods, the HbA1c, whatever, the blood pressure, all in relation to his LTCs, were all within the parameters that where you would want to see them. So we can conclude he had 20-odd years of good care. But Jackie was just, you know, just pre-EFI. And if we want to think about how we could have stopped him or slowed the progression to severe frailty and even end of life, then we need to start to think about, well, if that's 20-odd years of in and out of primary care, what do we need to do so that we start to spot the time that he stops coming on his own and his wife's with him, the next time he comes and he's walking with the walking stick, the time after that when his daughter wheels him in a wheelchair and he's newly bereaved. So what can we do to spot all of those opportunities in primary care? Because the bulk of Jackie's care happened in primary care, and his episodes of secondary care and his use of social care and domiciliary care packages, they were small in comparison to all of the years in primary care. And to pick up on Lynn's point about, well, how does the 95-year-old present in front of you severely frail when they haven't touched many of the services? Maybe that 95-year-old, like Jackie, had loads of points of contact with primary care where they could have been picked up.
That's really useful, Leslie. I'm just seeing if there's any more. Lynn, is your hand historic? Popped your hand back up there.
I popped it back up because just before the two Leslie spoke there, and certainly the things Leslie just said about primary care there, I just recalled the pilot that happened last year across Newcastle and Gateshead, I think with 4 or 6 practices, because it was my colleague Helen Kleiser that was involved with it more. But it was actually looking at the year of care approach in terms of falls and frailty. So when Leslie was mentioning there about the blood monitoring, the BPs and that, this was all about proactively identifying people where your the primary care conversation was more tailored about all of those other things and what's important to the person, and, you know, whether they were feeling more slowed down, whether they were relying on other people more, you know, whether feeling more unsteady. So it was, I don't know if people are familiar with that year of care approach, but it was where you have 2 appointments. Your healthcare assistant does the first appointment, then they go away with a questionnaire with some key, you know, key trigger words to frame a conversation when you come back for your primary care appointment with your primary care nurse or GP. And I think that, you know, there was some research attached to that. I'm not sure it's published yet, but I think one of the big findings was that it raised primary care staff's confidence, particularly nurses and healthcare assistants, around framing that conversation around frailty and pre-frailty, you know, fear of falling and all of those things. So I know that was just a little kind of test with the year of care work, but it did seem to kind of reap some rewards. I'm not sure about the kind of, you know, the more hard data like, you know, unscheduled visits and that. I would be able to get that from Helen, but certainly did seem to show some benefits.
Absolutely, Lynn, that it's useful. No, I think we did have some conversations with the Year of Care guys and how they really expanded their sort of multiple morbidity clinics into the frailty arena. And I think their work's obviously still ongoing and things. I'm trying to remember who's our copper who used to join us for that, who used to lead the work. Sue.
Sue, Dan, yeah. Sue, what was her name again now? It was definitely Sue.
And I'll keep us right.
It was Sue Roberts.
Sue Roberts.
That's right. Thank you,
Yeah, there's definitely some publication or some research that if it wasn't ready, I think it was with Newcastle University and the Year of Care team.
I can see, Lynn as well, HSN put some funding toward that, and we did get an end of project report, so I can try to dig that out if you want.
That would be great, Anne, to share that.
To share it, yeah.
Kim's got a hand up. Before Kim just speaks, I want to try and, can we have a think about, we've been very health focused, which is great. Think about the wider determinants. I know we do automatically, but I'm just trying to think of some voluntary sector guys on the call or anyone else outside the traditional health sector as such, and how you meet Jackie in your world. I've got Yvonne's hand up there.
Hello, Yvonne Prober from Age UK North Tyneside. I'm head of charity services. I think with Jackie, one of the joys of the voluntary sector is actually we're with Jackie right the way through. Because if you take the trajectory of Jackie, he may well have been in one of our standard community groups. That could be a cuppa club or a local exercise class such as Tai Chi. And then obviously as his life progresses, he would touch on other services within the voluntary sector, not necessarily Age UK's, but generally within the voluntary sector as a whole. So we probably will chart around that, because there will be carer support through something like a carer centre, or there might be work through Admiral nurses for dementia. But there's a real wraparound from the voluntary sector, and I think we often can see deterioration, but are powerless really in order to try and raise that with somebody in particular who can do something about it. That's what I want to say.
And I think on that, and that's part of this. You sat on this wealth of intelligence about these people. I won't be crude and call it dirty. And there's no way of us harnessing it and getting it together. Which is crazy in this day and age when things are passed around so easily. But yeah, that's exactly kind of and you'll see them, as you say, right through that journey. But from think about that from that left hand side as well, and that's where we need to get smart about it and pick those things up. So the services are alerted to these people and with the right level of kind of risk on there, because back to the point that was made earlier, we can't just take everyone and kind of refer them in, but there is something about being able to stratify that. We just need to find a way of cracking it, I think.
So I've got one quick question, Yvonne, hopefully not putting you on the spot, but is there any way you capture these sort of names and lists of people and from a monitoring or follow-up that you think is potentially shareable or useful, or just how do you actually from a Age UK perspective actually keep these people's lists or the data as such?
So we have, for Age UK North Tyneside, I can only speak on behalf of our organisation, not the voluntary sector as a whole. But for our organisation, we have a customer relation management system. So all of our customers are registered, and therefore we've got the data with them. So we can tell you ages, we can tell you localities, We tend not to keep much from a health point of view unless it's something that's relevant to the activity they're undertaking. But I think one of the things I just wanted to add in on the back of the data side of stuff is quite often we pick people up as well when they come out of hospital. So that other end of the spectrum. So we provide things like we're working with the Enhanced Care Point in North Tyneside around making sure once all the clinicians have finished doing all the medical stuff and put Jackie back out into his home in the community, that there's wraparound there for the social, the isolation, and all of the softer things that actually keep Jackie out of returning to primary and secondary care. And some of that data capture is really, really difficult, because how do you capture, and I know there's a whole range of scales and things, but how do you really capture that impact on a person for them returning home?
That's really, really useful. Just to, I think, Kim, you might have put your hand down now. Was that by mistake, or did you want to jump in? Because Jenny's got a hand up, if not.
It was just an observation, really. So we're always really good, and I'll hold my hands up, in counting things that we know about. And I think I was just touching on that point about that 95-year-old example of suddenly, hitting a sort of a real emergency in their life course, as it were. Is there something we think about where you look at cohorts of people that haven't had a contact in a certain period of time, or have had certain contacts in one area and not in others, because it's almost counting the lack of contacts rather than the actual contacts? So just an observation and something for us to think about how we might do that. And I was going to bring up the voluntary sector, so Dan, you teed it up very well, so thank you.
No problem. I think Jen's got a hand up as well.
Yeah, thanks, Dan. Yvonne, I'm really saddened to hear that expression that you gave there, but I hear it more often than not about you just don't know what to do. You're spotting these people deteriorating in front of your eyes, but feel helpless and not knowing what to do. And that's the bit that we need to kind of capture to know, because we know that there's lots of different places where that's happening. And I often hear people saying, if only we could have done X, Y, and Z. And that's what we're trying to kind of almost unearth. What is that would make that difference? So I think, given I'm again putting you on the spot, do you know what that is? What could we help make happen? Because you've got, an audience and some appetite to make that difference.
I think things are changing, and I think that's a really good thing, because I think the fact we're going down to a much more locality-based way of working in the primary care networks, I think it gives the voluntary sector of various sizes the ability to plug in, and I see that as a real positive sort of step forward. Because instead of working with, from a North Tyneside point of view, working across X number of GPs, it's now more defined, and that therefore makes it easier to quantify and be able to open doors to. We've also done quite a lot of work in North Tyneside. Again, I can only talk for North Tyneside, around there being a voluntary sector lead. And in particular, the North Shields locality have got a voluntary sector lead who basically feeds into the primary care network and those GP surgeries that I suppose it's that background sort of intelligence about the voluntary sector and what's happening. And I think that's opening doors.
Brill. That's really good to hear. I guess what we need to then establish to help Kim and Ian from a data perspective is how do we capture that so that we know where that's working really well, which sounds like you're doing in North Tyneside, and where it's not working quite as well, so that we can demonstrate that but also show the progress that you're making.
Can I just interact then with so one of our contracts that we have is with the CCG in North Tyneside for dementia services, and we have 7 Admiral nurses that are based in the community. And one of the things that we've struggled with alongside with the CCG is to try and find data sets that we can use to demonstrate their impact.
Yeah.
And And because Admiral nurses predominantly work with carers rather than the person with dementia, it becomes like 2 steps away from the data sets. So we've been looking at, could we look at hospital readmissions for somebody with dementia by the carer being more supported by an Admiral nurse, or the reoccurrences to hospitals appointments, are they reducing? But it becomes quite tenuous, and I think that's the bit for the data sets that becomes quite a headache to try and work back to where you can show a definite change.
That's really useful to hear. Can I throw a little challenge there? Is there anything from, if we think bigger, and if we think about the region and things, is there any piece of work or conversation that needs to happen with Age UK and our data intelligence people and things to try and link up this a little bit better? I'm just thinking about the app that we have now for the clinical frailty scale. I'm trying to think about the data Age UK keep obviously across the region. At least a conversation might be useful to have.
Definitely.
And that would be great, Dan. I'm starting to shiver a little bit thinking about information governance, but let's not stop talking about it yet, because information governance is there to keep us all safe, not to stop us doing things. We'll remind ourselves on that. So that would be a fantastic conversation if we hook up with maybe through Yvonne and set something up. And just, again, it's out of the possible, isn't it? We don't know until we start taking a few layers off that on what is possible, because Yvonne sat on a great patient data set there of people that aren't flagging to us. So what a fantastic way of moving that forward.
Yeah, happy to do so.
Now, I'm just mindful of the time, but I think Louise has just popped her hand up now, so I'll let Louise jump in there.
I was just saying that it's really about everybody collaborating, isn't it? So everybody's got some part of the information and you all have to share it with each other in some way, shape or form. I'm working a project in Southwick and Sunderland at the minute, which is about everybody in the community collaborating around Southwick, because the council had they did a piece of work to find out how people felt about their areas, and they didn't get a very good response from this place because of antisocial behaviour and all sorts of things. And so we've now got health services, the police, the fire station, everybody collaborating around a couple of practices in Southwick, and it's really coming along really well because everybody's working together and sharing the information. It's not necessarily about frailty, it's about mental health that we're looking at, but it really adds something to the conversation when you've got everybody sharing the information. So it's how we do that, I think.
Absolutely. So I'm mindful of the time. I just want to throw one last layer to the complexity, because obviously the identification's the big thing that we've been talking about today, but it's then what then? So what do you then do? And that's the whole challenge we all have. So some useful information to overlay in this obviously is all the workforce stuff. And I don't mean workforce from NHS, I mean the broad workforce across the board. And there has been a bit of work done across the region on looking at workforce modelling tools, and we've piloted something in Gateshead, looking at a tool which helps PCNs to understand their workforce needs and future needs based on population need. So maybe that's another piece of the jigsaw we have to start throwing into this going forward as well. Stunned silence, but I think it's a complex area. But I just thought, when Yvonne was talking about Admiral nurses and workforce, that is always the next question, isn't it? So what and how do we then manage?
Yeah.
And Dan, I think the other bit that we need to be really cognizant of is the workforce that, for example, Yvonne's got within her organisation and other voluntary organisations, but also other agencies, so care agencies, things like Care Connect, etc. It's that broader, wider workforce that we need to be thinking about at all of those different levels to support this population. And it's how do we link that in with the work that Ian's doing and that workforce work. So again, no answers, but just making sure that that's kind of at the forefront of our minds. And as we're going back to our localities, be thinking about that, and then, you know, coming back to us with sort of those nuggets of information or things that you suddenly think about, those light bulb moments that think, actually, what about, and share that, because we're all kind of learning and finding our way with this.
Absolutely. So I'm mindful of the time and other things that we've got to get to. Is there anything else we need to finish up with, Ian, Kim, or Bob, or?
What we'll do now, just we'll compare our notes. I think a few was taken over there. Just feedback the conversation, so we've got a written record, which I think is just important for us. And then Bob picked an action up there, but we'll certainly hook up with Yvonne, or get the right conversation going, because it's a place to start. Age UK is a place to start, and there are other people that will want to be in there. But have that conversation first, because that just seems like too good an opportunity to miss, because we've actually met on the screen today for an hour. So yeah, we'll do that.
Great. Well, thank you so much for spending your time doing this and the preparation and things. It's really appreciated. Really, really, and is so important. And obviously getting up there on the agenda for the whole population health management approach going forward. So it's really, really useful.
Oh, thank you.
More than welcome. You can go anytime you can come.
Thank you.
Just moving on to the next item. So we're going to talk about Rita. And I think that's a project around sort of dementia and care homes. And Anne, you'll have to keep me right, because I haven't got my agenda in front of me. I think we've got about 20 minutes, half an hour to have a chat about that.
Indeed, yes. Hi, Daniel.
Okay, so I'll hand over to Mike. Is that all right?
Thank you. Yes, thank you. Hi, everyone. Afternoon. Thank you for inviting us for a start to your meeting. I've got my colleague Fiona also on the call.
Hi.
Here. She's been very, very heavily involved in some of the work that we've been doing in care homes. Well, I say all of the work we've been doing in the care homes in North Tyneside. So she'll be able to give some lovely anecdotes, some of the major outcomes. And what I will do is give you as quick a presentation as I can, just to give you a bit of background of Rita. And then if anyone has any specific questions of the technology, I've got Fiona on the call who will be able to show you some of the technology, if that's okay. So I'm going to try to do what's technically easy, but never is. Presenting. See, that's done in the first hurdle there. Right, here we go. Right.
There we go.
So, can you see my slides? Hopefully you can.
Yes.
Brilliant. So, Rita. Rita, as you can see there, stands for Reminiscence Interactive Therapy Activities. Actually, there's also another name for it, which is Rehabilitation and Interactive Therapy Activities, which is the more generic Rita, which is being used in ITUs at the moment, very, very appropriate to long COVID, and also with children's services as well. We've got Rita Kids, but its home really is Reminiscence Interactive Therapy Activities. Now, incidentally, that name was brought about from a great relationship we have with Northumbria Healthcare. They wanted to give Rita a persona. Obviously, many people are quite daunted by technology, no matter how easy it is to use. And obviously for our more complex patients, and certainly dementia and those suffering with LD and so on, even more so. So they wanted to give it a persona, and Rita has become Rita and a she. And we've got a baby Rita and a mummy Rita, which you'll see in a minute. All terms used by our customers, I have to say. So what is Rita? It's ultimately a digital support for primarily geriatric care, dementia, ABI and LD. But as I said earlier on, we've got a lot more generic use of the technology, and it's been used really well with children as well. So what it is an all-in-one touchscreen solution that historically has offered digital reminiscence therapy. Obviously, reminiscence isn't that old, but digital reminiscence is a little bit more fresh and new to the fields of nursing and healthcare. it's obviously there to support the older of us, but in particular people with mental health issues. And what I should also add to this point, and I normally do right at the beginning, but I forgot, is I've got a bit of a personal agenda with this, because my mother sadly was sectioned 10 years ago, and she's been in and out of mental health hospitals and care homes throughout that time. So I've got first-hand knowledge of what it's like to be a family member, also what it's like to be the person in the facility, but also I can see how difficult it is for the carers as well, and obviously more so right now during COVID. So what it encompasses is we term it a package, and a package is an interactive touchscreen 24-inch monitor that comes with a trolley, and that tends to be used for more group activities to help with social inclusion and obviously entertain and keep people stimulated. And we also have the baby reader there, which is the 10-inch tablet, and that primarily gets used for one-to-one activities, one-to-one therapy and care, for those individuals that are either socially excluding themselves or are deteriorating or escalating in behaviour. Fee would never forgive me to not say the bit in red there is very important. Doesn't seem like it, but it is. It does not. 95–96% of the technology that you see, and you will see, does not require Wi-Fi or 4G to work. Certain elements do, obviously, downloading newspapers and ebooks and voice video calls and so on. But ultimately, the rest of it is all preloaded and available. That's all the music and films and games and you name it. And that's very important because, unfortunately, anyone working in healthcare will know how great our Wi-Fi is. The last thing you want when you're caring for an individual who's quite distressed is seeing that buffering wheel of death, which I hate watching football, and I can imagine it's a nightmare for carers as well. So the other thing that I really wanted to kind of mention that I think is really important, and it comes down to how I see it from a personal perspective with my mum, is the person-centered care part capability within the technology. So a lot of what you can see flicking through there and what I'll show you earlier on the Rita tablet can be profiled. And what I mean by that is you can set up a profile for all your residents, or if you've got long-term patients, your patients, and then from that moment on, whatever you use in that profile, whether it's photos, music, films, TV clips and so on, images as well, you can favorite that for that individual. But importantly, you can put a note in there as to why that piece of content resonated with that individual. And it's incredibly powerful for continuity of care. So I'll give you an example with my mum. My mum, like many people suffering with mental health issues, loves familiarity and loves consistency and hates the opposite. And especially when someone she doesn't know has come in and has to care for her. And that could be because her named nurse has gone on holiday, and then other staff that she knows really well have gone off on sick, for argument's sake. So you imagine an agency nurse may come in, wonderful agency nurse, could be in their mid-20s, but doesn't know my mum. And the first thing she will be greeted by is probably swearing, shouting, and get out of my room. And obviously, human nature, you think straight away, God, you know, that's you know, it's just not enjoyable, to be frank. So the beauty of Rita is, for a lot of care homes that we work with, it gets brought out as a standard operating procedure, especially for new staff. And it gets brought out, and if any patients were to deteriorate or get distressed or need to be taken away for a bit of one-to-one, they can bring out Rita, open up their profile, and lo and behold, they know that there's a music track that they used to dance to with their husband back in 1948, 1950, and so on. There's a movie that they used to watch with their families in the 1970s, and so on. And suddenly that individual, who my mum didn't like very much 5 minutes ago, they've got something to talk to her about, and something that resonates with her positively. So I'm going to rush through this because Fee will be able to show you more. But what do we have within the technology? We have communication support, so apps to support with pain identification for those that are non-verbal. We have Hear Me, which is a live translation tool, which historically was used for learning difficulties in the main, but ultimately it's being used across all settings now for any condition. And it's great for translating for individuals that do not have English as a first language or do not speak English as a first language. We have the phone, video phone calls, Zoom, Teams, Skype. The person-centered care facility, I talked about how you can profile and favourites, but we also have My Life passports, which are brilliant summarised documents which can then be handed to ambulance staff, patient transport, other service settings that a patient might need to go to. So again, they can speak to that individual and understand who they are and what their likes and dislikes are. And we also have the lovely digital life story work. We have a significant amount of sensory and relaxation. This is one of Fee's favourite parts. What's very basic, the outcomes that we achieve from this this content is staggering. It's used for helping with nutrition and hydration at meal times to calm people down. I don't know about anyone else, but when I'm anxious, I don't want to eat. Same for everyone else. Keep them calm. Just running up to the meal time and throughout, they're going to eat and they eat better. It supports relaxation, sundowning, sleep therapy, and it's even been evidenced to help reverse delirium as well. We have creative stimulation apps, painting. You can even build your own My Aquarium and your own garden. So someone who used to love gardening when they were mobile and able to be to do so, they can have a digital garden which they can build from scratch. We have quizzes and games stimulation, jigsaws that you can use images, your own images from. So photos from the residents' families, the carers who are caring for them. Do a few funny photos and use that as a jigsaw. We have quiz time that gets used phenomenally well in care homes. It basically is your pub quiz. We have a number of games that support with high hand-eye coordination. The whack-a-mole and free kick, whilst you would think, oh, they seem like good kind of good fun games, the reality is they're in there for a reason and they can really support hand-eye coordination. And then we go into our reminiscence. So we've got photographic reminiscence, we've got TV and video reminiscence. This is old clips, TV, movies, famous speeches, the 1966 World Cup there. We've also got Morecambe and Wise, Dad's Army, Are You Being Served, all of the crackers that we remember from growing up. And we have music, and obviously music is absolutely amazing for supporting and de-escalating situations and for reminiscence. And again, you can see a star there at the top right of that image. That is our favourite. So you click on that, favourite it for that individual and put a note in there as to why it had that resonance. And we have radio shows as well, such as The Goons. And then finally, content-wise, and this isn't all of the content, we'd be here all day if I were to do that. The final one is movie nights. Now, great, it is absolutely great for entertainment and keeping people occupied, but ultimately it's also a good reminiscence capability because there's films in there that have worked so well for residents and patients. You know, the old black and whites, the westerns, the musicals in particular. Fee's got some good stories about the musicals. So this is a video from Katie Pritchard at Imperial College Healthcare. And the last few times I've done this presentation, it's refused to play, and it looks like it's going to do it again, which is very frustrating. But I can probably share the slides with you in any case, and you'll
we
be
can send the link, can't we, for the video anyway? It's only a minute long.
That would be great.
Some of you will recognise that one.
So this is Ruth actually. I've got to show this one because it's only a minute long. Bear with me. No, not going to work. Love technology. Anyway, I'll show you the videos via the link that we'll share. But going on from that, where is Rita used? Realistically, where is it not used? It's used in over 1,000 care facilities across the UK, and it spans every setting: acute, community, mental health, care and residential, LD homes, step-down units, ABI homes, hospices, and even a prison in Hull, believe it or not. We all forget sometimes that everyone in prison suffers with the same ailments that we do. So obviously this is the most important thing for me, and this is the thing that blew me away when I first saw it. I've been with the business now for 12 months, and these are some of the outcomes that we're achieving. I won't go through every single one of them, but this is a mix of different settings. So we're seeing a reduction of falls. What you would have seen in that video from Katie and Ruth was talking about reduction of falls. Because people are being kept stimulated and entertained and occupied during the day, and their person-centered care is more meaningful. They're keeping occupied during the day and not sleeping at night. Occupied during the day and therefore not sleeping during the day and waking at night, which is when falls predominantly happen. And we have seen evidence-wise, and this is not our stats, these are stats shared with us from customers, ranging from about 36% in some care homes up to 77% in a hospital in North Cumbria. Staggering changes. And this all comes down to just simple change of behaviour, understanding how we can change people's sleep-awake cycles and have such a remarkable impact. And we also do a lot of exercises within the technology as well. We've reduced specialing significantly across all settings, and where we do need one-to-ones, they're being improved tenfold. And the feedback we're receiving from carers and staff is staggering. We're reducing length of stay, delayed transfers of care, and the big one for me is hospital admissions. And this has been evidenced at North Tyneside and Dudley. Dudley and North Tyneside invested very heavily in their care homes from a local government and a council perspective. That's some more detailed ones. Again, I won't run through these. I'll share the slides with you afterwards. And this comes quite nicely after the Ruth video that, if it had played, would have been nice. This is 2 of her care homes and some published CQC or extracts from published CQC reports. And as you can see there, they actually name the technology and they talk about the impact it's having. They were there watching how much of an impact it had with their care homes. Staggering. And then the final thing I wanted to show you is, this is my end goal. This is my absolute we can do it and we will do it slide. So we've got Rita being used in many large regional care settings, and we're having some amazing conversations with Public Health Wales at the moment. Every health board in Wales and a number of care homes and local authorities have Rita. So we're now talking to Public Health Wales about how we can join all of this up, embed the technology as a digital support for within their dementia standards. But importantly, I am now talking to Welsh Ambulance and a number of acute health boards and the care homes about how we can have Rita across the entire pathway to keep them happy, distracted, calm, less agitated, the care more meaningful. I called it the digital person-centered continuity of care. We've got great continuity of care when it comes to medical records, lots of electronic medical records now, but sometimes, not all the time, but frequently the person is forgotten, who they are, what their background is, what their likes and dislikes are. And this will give them an opportunity to take that with them, but also keep them calm and less stressed on the way to hospital, patient transport, in hospital, A&E, in the wards if they need to go onto the ward, and then back on the same rate of care that they were on within a decent time frame back to their care home. I've got one very, very powerful example of how that doesn't happen, and my mum is a great one. She needed to go into hospital for a major operation. She had to come off of meds. She obviously on a lot of mental health meds, had her operation. She's in a place she didn't know with people she doesn't know and off of meds. You can imagine what her behavior was like when she was recuperating. Awful. And she was spitting, she was shouting, she was swearing, and she was doing this to me and the family, but also the carers. And I could see the look in one of the nurses' eyes. And I do not want to state that this is a criticism, because it's not, it's human nature. But I could see that look of, oh God, we got one of those ones. And straight as soon as I saw that, I then went and spoke to all the nurses and I said, do you know, my mum is an ex-nurse. She's an ex-RAF nurse. She's an ex-manager of a care home. And she's my mum. And before I knew it, they had her up at the nursing station talking about what she did when she was in the nursing profession and engaging with them. And she got quite occupied and calm throughout that process. So that's what I want to achieve using our technology, as well as education for people to understand the power of that technology, because it's not the technology, it's the technology in the hands of in the hands of people who understand the outcomes that can be achieved. So education is a very key part for me as well. So
Thanks,
sorry,
Mike.
Fee, do you have anything to say? I'm conscious that, as always, I can't
Yeah.
help on. But
I'm not allowed to talk anymore, because anyone that knows me, because I know Yvonne, I've met Yvonne a couple of times from North Tyneside, Age UK, so hi. But anyone that knows me knows that I can talk for Britain about Rita, so I'm not really allowed to. When there's 20 minutes, I'm not allowed. And Mike's the one that doesn't talk as much, so you can tell what we're like about this system. So I have been involved in the North Tyneside rollout. So I've worked with Ruth. We have embedded Rita into the North Tyneside care homes extremely successfully. There's been a white paper that's been produced by an independent consultant and looked at, a lot of the outcomes that the homes themselves had provided for us around their falls and their specialing requirements. And the well-being of their residents. And I know I do speak to the homes regularly, and I know that they are using it extremely well. We did a sort of mini update, if you like, with the homes during COVID, because one of the things that we were very conscious of was when we did the big rollout, because obviously 31 homes in North Tyneside, we wanted to make sure that everybody was using it, and they were all using it phenomenally well. And we kept over the course of the first sort of 12-18 months, we were looking at that quite a lot. And then COVID hit, and Ruth actually came to me after about 2 months and said, obviously no visitors are in the care homes. I want to make sure the homes are still utilising the Rita systems, because obviously we're not going in and checking and all of those kind of things. And we can actually see the stats on the system, and the homes had actually doubled their usage in most of the homes, because obviously never has there been a more important time of having appropriate distraction for the residents than now, because the normal distraction that the residents will get by the hour of the daughter coming in and having a chat with them, or family members or friends, none of that has been happening. So they've needed to have that more of the distraction, an easy distraction for the staff to actually be able to provide, because it's not all down to the activities coordinators. I know sometimes that is the common misconception, that it's their job and everybody else just does their own job, but actually being involved in those activities, being involved in that meaningful interaction and that engagement actually has such far-reaching positives for the residents or for the patients or whatever environment you're in, that it does help, with compliance when you're giving meds, when you're, asking people to do things, when you're trying to get people moving, or, whatever it might be. So we have found that, it's been extremely well embraced in North Tyneside. In fact, the CCG did buy a system for all of the homes initially, and then within about 6 or 8 weeks they'd actually bought another system for all of the homes, because it had gone so well and they had access to funding to thankfully do that. And it has been a fantastic project to be involved in. But I think ultimately right now, we're getting a lot, we've been busier than ever, because a lot of the clients that we've worked with before are ordering more systems because of the appropriate distraction, because of the video calling, because of the infection control issues, and making sure that people can have that communication with their relatives. But also you've got the other element of, sorry, lost my train of thought. Because I'm just thinking about doing a presentation. So I'm very conscious of time. So am I okay for literally 5 minutes to show you the system? I know Yvonne's actually seen it, but has anybody else seen Rita? Does anybody know what I'm blathering on about, or what Mike's been blathering on about for the last 20 minutes or so? Has anybody seen the actual system? No? No. So I think it's really important just to put it all into context. We can sit here and spout figures at you until we're blue in the face, and we probably would do, to be perfectly honest with you. But the reality is, I think you need to see just how simple it is. And you know, the fact that everything is preloaded, the fact that it's very simple technology, the fact that a lot of the residents and patients can use it independently is one of the main reasons why it is utilised so much in all of the environments that we work in. Okay, so the system itself, if I just share my screen, this is where it often goes horribly wrong, as Mike said. But the system itself, when you turn it on, you literally come up with the Rita home screen, and that will guide anybody towards content. So hopefully you can see that, and that's obviously very similar to what Mike showed you on his slides. But I think it's important just to get the concept of it. So down the bottom, it actually says logged in as guest at the moment, but what we can do is we can press the two heads and we can actually put somebody onto the system, their name on the system, and we can start to build these libraries of content from the generic content that's already in the system. Okay, if you want to listen to music, it isn't rocket science. You literally click on the music, radio and relaxation icon. It brings back all of your music themed content. I can click on music. We can scroll through, we can find something that's relevant for somebody, and you've got everything from blues and Christmas, country music, hymns, right the way through to pop music to the present day and soul music. So you can select whatever you want for that individual or that cohort of patients or residents, and it will start to play until you turn it off. You can skip to the next song if you don't like it, and you'll see that star has turned gold. So if I click on that star, there's been a note put in there that Dad sang. My dad did used to sing Glen Campbell to me, which is why I like him. But the way to do it, it's so easy. So if this was somebody's wife's favourite, you press and hold on the star. Yes, I want to make it a favourite. And then we could just put wife's favourite. If you're specialing somebody, if you're delivering one-to-one care and you've just had that moment with that resident or patient and they've given you that information, it's really nice to capture it for your colleagues, to be able to then to be able to use that as a distraction, as a comfort, as a support. And that's why the system is used so well. So what actually happens when you favourite it as well is it goes into their own personal music library. So whichever account you're in, you can go in and we can find all sorts of music that is relevant and appropriate for that person. And more importantly, we know a reason why it is a favourite. You can search for music by artist, by song, or by decade, which is a very used thing as well. But hopefully you can see, I thought it was really important to show you just how simple the system is, and you just access whatever you want, if it's audiobooks, if it's poetry, if it's radio shows, whatever. The one that Mike mentioned, which is my little baby, is the relaxation, and this is used all the time. Now, we actually have a case study for every single care home in North Tyneside with the project that we're involved in there, and every single home uses relaxation, and pretty much every single home have used it at an end of life situation as well, just to give that comfort and to drown out the normal noises that are in a busy care home or a busy environment or a hospital ward or wherever it might be. It just gives a little bit of peace of mind. But you've got all of your different stuff, so you've got waves and fireplaces and all sorts, but this is what I call spa music, all of the stuff at the start. So you've got very inoffensive background music that will start to play, and then you can click on the eye and you can change the background, so it's very, very calming. Most of the managers of care homes want one of these in their offices, to be perfectly honest with you, but it's not for them, it's actually for, well, it is for them as well. It's to make their jobs easier. And at the end of the day, I've said it a number of times just recently, care home staff at the moment, they, as far as I'm concerned, they have one of the hardest jobs out there. I know hospital staff are under it at the moment, but ultimately they have an end goal of discharging that patient, getting them well and discharging them. But I think for care homes, you've got people that are very distressed. They can't understand why they're not seeing their families, and it's just a really difficult time for everybody. And it's about just giving that comfort and that distraction. And we find the relaxation is really good at supporting people. It helps with sleep therapy. It helps with everything. So it's my baby. I think it's wonderful. There's your movie nights, your videos, all sorts of things. You've got your armchair exercises, which I do think is important to mention. I don't know whether Yvonne's used it at Age UK, but I know that the homes use these all the time. They're chair-based appropriate exercises. If you've got somebody who's isolated in a room on their own, then they can do some exercises in a group, they can keep some movement going, or you can do it as a group activity, and it's fantastic, and we use those all the time. We're actually at the moment in the process of putting some breathing exercises on as well, because the hospitals have actually requested that, because they need the breathing exercises to support some of the patients. So, you know, we are doing that. We're looking at putting those on soon. So you've got all your activities, your games, your quizzes, your word search, which is very popular, your apps and creative activities. So there's the aquarium, which is my favourite, higher or lower. We'll mention greeting cards as well, because this is a big one. I've been doing a lot of training with hospital wards and care homes, and again, it's all around managing the expectations of family members at the moment, because they're as stressed as everybody else with not being able to see their relatives and not know that they're okay. I think, you know, we're coming up to Christmas. It's a really difficult time of year for people because they want to get together. But how nice to be able to create a greeting card on the Rita system and actually just email it straight from Rita through to the inbox of the relatives. And that is a really nice thing to be able to do, because you can take photographs of the resident, you know, and put that on the card and send it through. They can sign the card and send it. We're doing that in hospital wards. We're also doing that, you know, in care homes. You've got your Zoom, you've got your Skype. I'm talking to you through Rita right now. So you've got Teams as well.
Hey, we've got some questions.
Okay.
There's three. So we're limited with time. So
yeah, I'm just mindful of the time. So we've got, I think Leslie might have had a hand up first, then Yvonne, then we've got Lynn after that.
Okay, let me come back to you guys.
Yeah, hi, it's Leslie Young-Murphy. I'm the Exec Director, Nurse and Chief Operating Officer, North Tyneside. Hi, Fiona. Hi. I have to say this has been one of the biggest success stories in terms of digital making a difference to care delivery, not just with patients, the carers, but also with the whole care home staff themselves. I mean, some of the impact stories that we've read, I think a few of us sat and cried when we started to look at the difference that can make by intervening, you know, in an appropriate way. We're linking with the memory clinic as well in Northumbria, and we've also, you know, to try and think about how we use things in a different way, but also with Northumbria University, which picks up on Mike's point in terms of, you know, how do we from the very beginning, in terms of undergraduate programs, this was around nursing programs, build in that using digital in a different way, particularly with older people from a reminiscence point of view, you know, recognizing about seeing the person who's standing before you. And I always like the phrase, you know, I am not the person you see, you know, I'm more than that. And I think that this allows that to be explored really powerfully. And I think the upload of personal photographs, linking them with the stories and the narratives, and the thing that always made me laugh, and that when they go down so well, the thing that made me laugh the most and that was the demand for more. So we bought big screens, you know, the tellies as well as the individual ones. The tellies are fantastic for some of the group work and obviously some of the smaller ones, but the reason we had to do more was because some of the residents didn't want to give them away back again. And to be fair,
I'm sorry about that.
we're going to end up in problems. But actually, you know, a couple of those residents, I think it's fair to say their behaviour escalated so significantly. And really, the behavioural support team, the people involved were at such a loss. I think one of the residents was about to be sectioned and moved into hospital. And there was a lot of work done. And, you know, that avoided that. And, you know, you cannot put a price on it, really, can you? So,
you can't.
Obviously, I'm biased, but you know, I can't sing the praises enough. I was just talking to Steve today, Steve Parry, in terms of the reduction in falls. So we're going to have a look and see what we can do in terms of taking this a step further in terms of the impact research. We'll probably pick a couple of areas and look at that. But I know we've got a meeting to talk about that. So that's me. I'm going to stay quiet now.
Thanks, Leslie. I mean, oh, sorry, Daniel. I would just say it's been an absolute joy to work with everybody at North Tyneside, and some of the results, I mean, we can email them round. I mean, to say tears were shed is an understatement, because some of the outcomes were absolutely phenomenal. And I met up quite a lot of the residents as I went round to all of the homes, and they really did embrace it. And it, you know, it was fantastic. But I think one of the really interesting things for me is actually seeing the difference with people. There's a lot of people that are old, like I am, who are technophobes, and I am the world's biggest technophobe, genuinely. Mike will concur. And I don't do computer games. I don't really engage with technology. What I loved when I joined this company over 6 years ago was the content, was that person-centered approach, was actually talking to people endlessly about Morecambe and Wise and all of those kind of things, which is a nice thing. And I have all of those memories because I'm old enough to remember them. But I think the interesting thing is, and one of the things that Leslie said about the staff, when you've got younger staff that are caring for older people, there's a massive gulf in knowledge of what does resonate with somebody, because I spend most of my working life explaining to people who people like Morecambe and Wise are, which is soul destroying for me, but you know, it needs to happen because a lot of the carers have no idea. But what they do like is the fact that it's all contained within technology, which is second nature to them. So they use Rita because it's technology, and they get the same end result because they're using the content and it's supporting those residents. But then the older people like me who have that knowledge but don't like technology will use Rita because it's very easy. So it kind of comes at it from both ends. And I think that's the important thing, because one of the questions that is asked regularly is, will it get used? And when I sat in the room with Ruth and Wally initially at North Tyneside, they loved the system, but they said, how can we guarantee that this will be used? And we guarantee it will be used, A, because we train people and we get them enthused about it, but also because it is so simple and it comes in at it from both sides. It's not complicated, so it engages everybody really. Sorry, I'll stop talking now.
No problem. So, you're going to get a couple of more people in, so I think Yvonne had a hand up and Lynn. Do you want to go, Yvonne?
Hi, Yvonne.
Hello. So I just really wanted to add in that the CCG were very kind and extended 2 Ritas to us, which we were very effectively using pre-COVID, and we were using them in our wellbeing centres when they were open, and we were also using them on our MCST course with the dementia coordinators, and they were going down a real storm. Unfortunately for us, when face-to-face work stopped, unfortunately our experience with Rita stopped, but they were going down really well. And I just wanted to say they can be put into other uses other than in a care home setting, and we were seeing really good results.
Thank you. No, that's brilliant. Thank you, Yvonne.
And Lynn, did you want to jump in?
Yeah, it looks absolutely great in all those settings. I just wondered, both professional experience and, like yourself, Mike, experience with my own mum who had Alzheimer's. It's often not just the physical health problems that trigger admission to a care home, but it's how draining and difficult it is for family members looking after people with mental health problems and dementia. And it's right the way through there. I was just thinking what a useful tool that would be for someone who was trying to get support with managing behavioural and psychological symptoms on a one-to-one at home 24/7. Hours a day, and it might have an impact on, premature admissions into care because families might feel able to cope for a bit longer.
We're actually doing something at Dudley around that, exactly that. So Dudley was the pre-runner to North Tyneside. So we've done a big project with the homes in Dudley, that Ruth and Wally actually spoke to Marie over in Dudley when they were looking to purchase them. And basically they've got them in their Age UK, they've got them in all of their day services. What they've done now is they've extended it, and they've bought quite a number of tablets. So that's the baby Rita. So that's a 10-inch tablet that has all of their content preloaded. The day service actually have bought quite a number of these, and what they're doing is they're selecting families and they are lending the tablet to those families for a 12-week period. They come in once a week, and they get additional training and they get tasked with things to do each week. So it might be to do the collage in the first week. So that's a life collage, overview of somebody's life pictorially on the front, and all of your really important things on the back, like mobility, eating, drinking, all of those kind of things. They can be printed off. They're a great document.
Yeah, because I think from personal experience as well, sometimes you get to the point where you have respite, but the ground that a husband or wife or daughter or son has to make up when they come back for respite. Yeah. So if somebody had 100%. That system, their self at home, all that passport and all favourites and everything could be preloaded, couldn't it? Because there's always that feeling of guilt when someone's in respite that It's meant to give you
And
a
it
rest,
is,
but
and
feel like you need to be there all the time.
you do.
So,
And the
yeah.
other thing is, and I'm sure Yvonne knows this, you know, when people come to a day service and they've had a really good day and they go home and the family say to them the next week, what did Frank do last week? Because he was really calm when he came home, but he can't remember what it was that he really enjoyed about the day. So we can document things like that. So because actually it's around giving the families the tools to be able to replicate the things that have distracted, supported, de-escalated, or stopped that escalation in the first place. You need to
did they have their dinner or not, and what did they enjoy eating, and all, you know, things that you're sharing across that whole pathway.
But it's that education, isn't it, for those people that are very, very isolated at home. They think they're the only ones that are going through it. But the reality is, and they're doing it in a group at Dudley, so they've got a number of people that are doing it together. They have it over a 12-week period. And at the end of the 12 weeks, hopefully they've gained lots of different ideas. They've got these anyway, so they've got the hard copy of those. They've got a PDF copy as well, so that can support them. But they've also then got oodles of knowledge of different things that they can do, maybe activities or whatever. And if they want to buy a Rita, they can. But that's not the point of the system. The point of this whole project with them is to give the families and the carers the tools to keep people out of a care facility for as long as possible.
I think it might be Leslie.
And it's working at the moment.
Leslie just popped up there. Could be on prescription. I agree. Probably the
absolutely, and we have spoken about that.
And respite costs and things.
Well, could I just jump in there, guys?
Sorry, yeah.
I absolutely love it. I'm just wanting to listen to the conversation. It looks absolutely great. I'm mindful of the time. I'm just going to throw a couple of things up to Leslie Young-Murphy and looking at sort of the evidence base behind this, because you know what it's like in the commissioning world from evidence-based perspective. Is there any conversations, Les, that need to happen with the regional ICS around some of this and obviously their digital agenda? Because clearly you're starting to collect data and information and impact that might be useful to share earlier rather than later. I'll just leave that with Leslie to have a think about, because that'll be useful. And also, you know, all the iPads, they're getting bought nationally, and we're going to get all the Barclay people to actually train staff. Has any conversations happened about applications and things of some of the national stuff that's going on? Because we are linked in with some of that.
I think that I've raised it, and I mean, obviously, this is not probably meant to be the way it's about to come out. I think sometimes areas are disadvantaged if they've done something and then somebody up the line decides there's something that they want to do in a different way. So I just want to say that we've also worked with Fiona to upload some other things in relation onto the devices so they can be used for multi-purposes, so they're not a one-trick pony. You can use them for lots of different other things, which is really important. So we'll have fed back up through the digital routes as well. One of the things I did agree was obviously we had the impact case studies which have been looked at independently. But again, a few of us with Fiona and Mike will be getting together to look at how we take that forward and do move beyond the sort of impact case studies to looking at sort of a bit more longitudinal research. And that to me then is what you really need to do. But if you're looking at value for money, and I have absolutely no connection, and I'm not a part shareholder, but if you're looking at value for money and impact, in something that has made a difference, when I think about the billions that the NHS wastes, I know where I would probably put some money.
Absolutely. So I'm going to move us on, but maybe me and Leslie and others can have a chat how we link the Aging Well networking and the ARC bids that might potentially be coming down from an evaluation of research potential, and also further conversation with ICS people in the digital world. Leslie, maybe we can pick it up a little bit further.
Yeah, no, that sounds great, Dan. Yeah, okay. Look forward to that.
Dan,
no.
Could I finish on one thing that I think it's just a lovely way to end it. Fiona had a call yesterday through the office phone that went through.
You'll make me cry.
Yeah. And a lady called Elizabeth, I won't tell her full name, she was on a ward in Bryn Beryl Hospital in Betsy Cymwalder in Wales, rang and said, "Are you the guys that make the magic machines? I really want one." And we're lending her one for home. We're shipping it off tomorrow because she's got no one. She's got no one at home. We asked if there's anyone
at home to look after her. Son's in Germany.
Yeah, as soon as she said that, I was like, right, we'll
Yeah.
ship.
And she got the number off the back of the machine. The staff didn't know. She got our telephone number off the sticker on the back of the machine and spoke to me yesterday afternoon and just said that she said it's the best thing ever. And when I managed to get back through to her late last night, and I told her that we were going to lend her one to take home with her to give her that support. And she cried and she said, it's like all of my Christmases have come all at once. And I just thought, you know, it's just nice. It's just wonderful to be involved with something that people do appreciate and enjoy. So we really do appreciate you having us today. And I'm sorry, we do talk for Britain. I am really, really sorry, but we'll send a lot of information out to you guys. And if anybody wants anything else, then please let us know, and we'll send it all through to you.
Thank you so much. If you send everything via Anne, then we can distribute out things and we can internally get together and have a think about further conversations. But thank you so much for coming. It was really, really good to see.
Thank you, and nice to see you guys. Thank you.
No problem.
Have a good afternoon.
Thank you very much. I'm just mindful of our last 7 minutes and not sure how much we can actually probably achieve, but let's have a little look what we had on the agenda, because I think we're still sharing screens. Let's have a little look. Is somebody still sharing their screen, or from the Rita guys? Does not look.
Dan, do you want me to try and share my screen and just get it to where we are on the PowerPoint?
Could you do that?
I'll try it, yeah.
But don't worry, everyone, because I've got a number of slides, but I'm just going to obviously not go through them all and just let you take them home and things. Perfect, Anne. If you can just click us on to the... Okay, so often we go through what's the latest. Now, as always, I try to keep abreast with what's happening in COVID and frailty, and I put it in the sort of template of frailty eye care. So there's some useful links that's been going on in COVID and frailty. And just let's flick down to the next couple one. Further, obviously a lot on rehabilitation over the last. And what I've also done is done a couple of themes for you. So just some thought-provoking things about what's happening. So the next slide down, Anne.
Yeah.
And that's just looking about care homes, frailty and COVID. Then the next couple of slides are more generic updates on frailty and another theme to think about in slide 12. So you can just take that away and have a little think about the whole inequality agenda that's happening. And the rest of the slide 13, 14 and 15 are actually updates on Jackie's journey, the digital tool and the workforce projects we're involved in. So that's a continuation of what's been happening. So you can have a little look at those yourselves and see what's going on, unless any one of my colleagues want to jump in specifically about either workforce or Jackie's story or CGA2 to give an update. But the slides do explain what's happening on them projects so far. I'm just going to open it up to Jen or Leslie. Did you want to mention anything about the projects that are going up at the moment? Any updates, or are we happy just to leave the slides?
I think I'm happy just to leave the slides and just say that if anyone's got any questions or queries, if you just email one of us or email Anne, and we'll get back to you.
Yeah, I was going to say the same. I think we can just leave it with the slides.
No problem. Okay, now obviously we've done a lot of really useful conversation happening over the last couple of hours. We often get updates from people in the community of practice about what they've been doing in their world, but I'm mindful that our world, we've got 4 minutes left on this at the moment. So has anyone got any burning things they want to share with the group for a minute or so? Or if you haven't, but you don't want to say it now and you do want to share something, please let Anne know what's been happening, if anything's changed over the last 6 to 8 weeks that you want to share with the group or have any conversations with anybody. So please put your hand up if you want to say something.
Or you could pop it in the chat box. I see Karen Franks has just added something there.
Dan, you're on mute, so we can't hear you.
I'm saying no. There's probably nobody wants to speak anymore. We've had a good couple of hours of chat. I think we're all ready for a cup of tea now and a bit of relaxation. So we'll share everything as we normally do. And does a link go out to the video recording site and things like that?
Yes.
Or does it all just go on the website?
Yeah, I tend to send the minutes of the last meeting and the link to it as well.
No problem. And if anyone wants to be involved in any of the conversations that we've talked about from the digital side with Rita or the data side with Next colleagues in Age UK, please just give Anne a shout, and any meetings that get arranged, we can link everybody up. So from me, thank you for everyone turning up. It's been quite a useful meeting. Has anybody got anything else to say, or are we all happy just to say bye and we'll see each other next time?